Well, many of the nation's largest nonprofit hospital systems, which give aid to poorer communities to earn tax breaks, have been leaving those areas and moving into wealthier communities as they have added and shed hospitals in the last 2 decades. Joining us on the KOGO News Live Line, Paul Seegert, managing partner at PCS Advisors, a health benefits consulting firm. Good morning, Paul.
Good morning. How are you today?
Good, thank you. According to a Wall Street Journal analysis, as these systems grew, many were more likely to divest or close hospitals in low-income communities than to add them. So have you seen this happen?
Absolutely. It ties in pretty well, and it's pretty analogous to what we're seeing in the rural areas where hospitals have been closing at a pretty rapid clip.
So tell us why this is happening.
Well, it really points to the underlying payment or reimbursement issue that we have in our system, where when your payers, your customers, are either on Medicare, Medicaid, or uninsured, you often, as a hospital, lose money on those transactions. And you rely on those with commercial insurance, private payers, employer plans to make up the difference. Often these hospitals will lose. They need 120, 140% of what they might collect from these government-provided programs just to break even. So they simply can't survive well, even with tax breaks, on those low reimbursements.
So, yeah, it's all about the money, but what should be done to make sure that people in poorer areas have access to health care?
Yeah, I think we need to take a very good look at the payment model and say, should we make some accommodations for facilities in those areas and perhaps reimburse them at a higher rate? We have done that for some of these to kind of stem the closure of some of the rural facilities, and perhaps we need to look at doing something like that for some of these urban poorer areas.
So the investigator also found that overall nonprofits are less generous in providing aid than their for-profit rivals. Have you found that to be true?
Yeah, you'll see behavior by some of these facilities where they have programs that a patient can apply for assistance, but they may not make them aware of it or do a good job of educating the patient until after they've attempted to bill and collect payment for care. And again, I think it has to do with the reality that they are struggling in many of these areas to get the revenue in the doors that they need.
I mean, it sounds kind of like, I know in the case of one of my family members that they don't make a whole lot of money, and they take a drug that cost a fortune. Now, they can get that drug through a program, but they put up so many obstacles and there's so much paperwork. You know what I'm talking about?
Yeah, I do. Absolutely. It's a challenge of our system overall. Drugs are, a perfect example of it. We make up 80% of the profit margin for the whole pharmacy industry in this country globally because of the prices that we allow some of these drugs to get sold for. And the trade-off is that we make these programs, like you mentioned, where people are supposed to be able to get access to the drugs, even if they're not in a position to be able to afford them or they don't have the coverage to pay for them. And you're right, we make it almost impossible for an average person to get through the process. And I think we're seeing some of that spill over into the way these hospitals behave when they are scrambling for dollars in poorer areas or urban areas or rural areas.
Paul Seegert, managing partner at PCS Advisors, a health benefits consulting firm. Thank you, Paul, for joining us. Really appreciate it.